Good afternoon, everyone. I'm Wulan, come from Department of Obstetrics, Zhongshan City People's Hospital, Zhongshan, China. I will give a case report, emergency presentation of Michael's diverticulum in the third trimester of pregnancy. First, I will give the presentation of the case, then I'll begin the discussion. Case presentation. A 25-year-old 32 plus 2 weeks gestation arrived at the hospital because of abdominal pain with a recent ingestion of spicy food. Approximately 4 hours later, she felt abdominal colic pain, which improved spontaneously or by changing position, with vomiting 5 times. Without diarrhea, she received the flofiglacical at a dose of 14 microgram IV in the outpatient department. Then she was transferred to the inpatient department for treatment at 4 p.m. Physical examination showed a pregnant abdomen, which was consistent with the gestational age. The patient had total abdominal pain, mainly in the lower abdomen. With tenderness and rebound pain, she had no noticeable uterine contractions, pain, or feelings of tightness. The cervix was closed. Ultrasound testing of the features and the placenta was normal, and the body testing are all normal. Feature surveillance was normal, and there were no obvious uterine contractions. This is the feature surveillance. We can see the baseline of fetal heart rate is normal, and the acceleration and the variation is all normal, and no early uterine contractions. So the patient was not considered to be in preterm labor. The cause of her abdominal pain was investigated, and acute gastroenteritis was considered. When she arrived at our inpatient department, we did not use dexamethasone, considering that there was no uterine contraction pain. 4 hours after admission at approximately 21:30, the patient felt increased pain in her left lower quadrant. She had total abdominal pain, mainly in the left lower abdomen, with tenderness and rebound pain. Strong, regular contractions were occurring every 3 minutes. And we started medication to prolong the period of gestation as soon as possible. Dexamethasone was administered to enhance fetal lung motility, and intravenous tocolysis with withdrawal was started. Intravenous sulfuric acid sodium was used to prevent infection. The white blood cell was 16,530, and the percentage of neutrophils was 88.2%. Precalcitonin, interleukin-6, C-reaction protein, pancreatic amylase, and the pancreatic lipid levels were normal. As the patient's abdominal pain worsened, we examined the routine blood and infection indicators again. The white blood cell was elevated to 20,670, and the percentage of neutrophils was 19.3%. Procalcitonin was 0.03 mg per microliter. Interleukin-6 was 44.9 pg microliter, and the C-reactive protein was 7.9 microgram liter. CT examinations are associated with ionizing radiation and are not advised in practicing, which could have a negative effect on the features, mainly depending on the absorbed radiation dose and the gestational age at the time of exposure. But this patient, we used the CT. This is a CT scan of this patient. We can see the left lower abdominal part of the small intestine was in a vortex shape. Down here is the vortex shape of the MD. The next morning, the patient continued to feel abdominal pain. The surgeon recommended emergency cesarean section in the obstetrics, and the surgeon would assist in the exploration. We performed a cesarean section. The APGAR score at 1, 5, 10, 15, 20 minutes was 10,999. During the operation, the surgeon explored the small intestine MD with a 316 degrees twist and local necrosis without perforation. This is what we find during the surgery. This is the MD, and some tissue is necrosis but not perforation. The MD was removed and sent for pathological examination, which showed acute inflammatory changes. Finally, the mother and the features recovered. This is the histopathological, and the histopathological findings confirmed the MD. Now, let's begin discussion. First, we'll talk about differential diagnosis of abdominal pain. Common obstetric acute abdominal pain include digestive inflammatory disease such as appendicitis, acute cholecystitis, acute pancreatitis, and bleeding disease, rupture, torsion, embolism, or obstetrician disease of abdominal organs. However, MD is real. In this paper, we reported pregnancy complicated MD volvulus, which attract our attention to the diagnosis of obstetric acute abdominal pain. When we managed the acute abdominal pain, we could also consider MD. Makers diverticular. MD is the most common anatomic abdominally of the gastrointestinal tract, resulting from the failure of the afferent duct to enlarge during the 5th to 7th weeks of gestation, and it has been described as the rule of tours. Prevalence of 2% in the population, twice as common in men than in women, located 2 feet from the iliac wall and can be 2 inches wide and long. Makers diverticulum is usually asymptomatic, and only 2% to 4% of people become symptomatic, usually in children. A small number of cases can be diagnosed accidentally by an operation or imaging investigation. Illustrate that most cases were diagnosed at emergency surgery. Symptomatic patients with MD present clinical features such as obstruction of the small bowel, painless bleeding from the rectum, and the signs of peritonitis. And the common symptoms include vomiting, abdominal pain, fever, and bloody stools. Abdominal pain is a very common symptom. Wherever nausea and vomiting were also observed. Symptomatic MD during pregnancy is an extremely rare event. There are no more than 40 cases reported so far since 1949, with 22 complicated by perforation and just only 5 is at the 3rd trimester. Our patient presented primarily with abdominal pain, which became predominantly left lower abdominal pain and eventually developing peritonitis. The first case presented with right lower abdominal pain reminiscent of acute appendicitis with subsequent findings of MD at surgery. In fact, appendicitis could be the most common surgical pathology in the acute abdomen, but some real disease should be also considered. MD should not be neglected as one of the differential diagnoses of acute abdominal complaints in pregnancy. Doctors find it difficult to diagnose MD complicated pregnancy because it can present unspecific symptoms such as abdominal pain, loathing, vomiting, and obstipation, which overlap with other conditions and can also occur physiological during pregnancy. Moreover, moderate leukocytosis can be normal for pregnant women but indicates inflammation in the population without pregnancy, make it more difficult to perform timely evaluations. During pregnancy, symptomatic MD should be distinguished from obstetric disease such as preterm labor, placental rupture, or chorea amnionitis. Ultrasonography is a common radiological investigation in the pregnancy patient presenting with an acute abdomen. Ultrasonography is not of great importance for adults, but it is of value in pediatrics because it avoids radiation exposure, especially having a higher sensitivity in cases of complications. In these cases, the ultrasonograph found nothing. MRI imaging are largely perceived as safe for pregnant patients. It has a higher sensitivity and specificity in the diagnosis of appendicitis in pregnant women. However, MRI could not be the first choice because of the duration of the scan and the resource availability, especially in emergency conditions. Technically, 99 AM. Particulate scintigraphy is regarded as a relatively good diagnostic tool, particularly in children, while lower in adults. The scan could be considered if MD is suspected. CT is common, but doctors can easily overlook MD, which could be considered a small intestinal loop without the presence of complications. When MD is accompanied by complications, CT is the best imaging study. In our report, CT showed the whirlpool sign indicating small bowel volvulus, combining CT results and peritonitis. The surgical chief thought it was more likely to be small bowel volvulus and suggested exploratory laparoscopy, but which we found MD complicated by volvulus. The mainstay of management for symptomatic Michael's patient is surgical intervention. In the asymptomatic patient, a conservative approach is well justified given the rarity of complications. We found 5 cases of microdurcotum in the third trimester of pregnancy. It's reported. As in these 5 cases, the gestation age is from 29 to 34 weeks. Everyone is suffered from abdominal pain and developed into peritonitis. 4 is diagnosis with CT. 1 is diagnosis with abdominal X-ray. For management, all 5 cases is performed surgeries and the mother recovered very well. Just 1 baby is in the neonatal intensive care unit because of low APGAR score, with APGAR score 1 and 5 minutes is 0 and 2. Elderly patient is presented with abdominal pain and had to undergo surgery. The mode of delivery was either vaginal delivery or cesarean section, which may occur at the time of surgery for the MD, resulting in preterm birth, requiring neonatal intensive care for the pregnant with MD. The trimester of pregnancy and the future mortality should be considered when deciding whether and when to do an operation. The risks and the benefits must be weighed against each other. That is the case report. Now I think you can take some message to home. Many diseases can lead to acute abdomen. While MD is a real cause of acute abdomen, CT is well for the suspicious diagnosis of MD accompanied by symptoms. When managing the acute abdomen, we must not forget the possibility of MD. For the pregnant woman with symptomatic MD, surgery is the preferred mode of management. That's all of my report. Thank you for your attention.